Welcome to my YouTube channel. Today we're going to talk about Hellp syndrome. Kindly make sure you subscribe. It will cost you absolutely nothing. So Hellp syndrome is just an abbreviation of hemolysis, liver enzymes, low platelets. So H for hemolysis, E and the L for elevated liver enzymes, the L and the P for low platelets. So this is a rare complication of pregnancy-induced hypertension, and as I said, its acronym is Hellp syndrome. For us to remember the pathophysiology of preeclampsia, we'll go through this. So kindly note that Hellp syndrome is a complication of preeclampsia. So we need to have preeclampsia for us to develop Hellp syndrome. So preeclampsia usually develops because of low resistant uteroplacental circulation, and therefore will now have subsequent impairment of the uteroplacental perfusion, and this will lead to placental ischemia. When we have placental ischemia, there will be production of oxidative and production of also toxin, and these toxins will enter circulations. Now, from here, this is what will actually cause the Hellp syndrome, where we'll have widespread inflammation, we'll have endothelial injury and dysfunction leading to altered permeability and vasospasm. So with this, we are going to have increased intravascular coagulation, which will now lead to platelet aggregation and aggregation, and therefore will later lead to us having low platelets. This widespread inflammation will also increase the permeability and also later increase widespread vasoconstriction, which will later now will lead to systemic hypertension and ischemia in various vascular beds, including the liver, and through that you're going to have elevated liver enzymes. So in addition to that, inappropriate activation of the coagulation system, as previously mentioned, you're going to have low platelets. And now this, as I said, will result to widespread vasoconstriction, and this will result to systemic hypertension and ischemia in various vascular beds, and extravascular fluid extravasation from the intravascular space. And this is one of the reasons, just to recap, why we give patients who come with preeclampsia adequate fluids and intravascular coagulation with progressive consumption, coagulopathy. Therefore, will have low platelets in the blood. So clinical features will have raised BP, this is a repetition, proteinuria, nausea and vomiting, epigastric and right upper quadrant pain. Because we will, as we have said, we are going to have systemic hypertension, which will include liver impairment, and ischemic and vascular bed, which also include liver cells. So we are going to have epigastric and upper quadrant pain because of the liver manifestations. So management, you treat just the same as preeclampsia by managing blood pressure using antihypertensives and prophylactic use of magnesium sulfate to prevent progression to eclampsia. Termination of the pregnancy. This is termination of the pregnancy. You have to terminate the pregnancy even if the pregnancy is young or old. You have to terminate the pregnancy. And then if the pregnancy is around 24 to 34 weeks, you can salvage the pregnancy and have another baby later. That is premature birth. Then you administer corticosteroids, which will help us in lung maturity, which will help us prevent a neck and also intraventricular hemorrhage. So in addition to that, because we have low platelet count, you give platelet or fresh blood transfusions, and patients should be managed in ICU until thereafter improvement in platelet count, urine output, BP, and liver enzymes.